Welcome to AETCM channel. A 50-year-old male who's hailing from Kannur, a shopkeeper by profession, presented with the complaints of like abdomen distension since 1 week, pedal edema since 1 week. So the patient was apparently normal like 1 month back because like last month he have developed like fever, cough, and then along with that abdomen distension was there. He was admitted in outside hospital. There he was diagnosed with the H1N1, and then he was treated there, and then he was discharged, and then after discharge he developed like again abdomen distension 1 week, along with the pedal edema was also there. Like abdomen distension was just gradually progressive, and then along associated with that he had developed like swelling of bilateral lower limbs, like mainly pedal edema was there. Otherwise, no other history of like no pain in abdomen, no vomiting, no hematemesis, no history of fever was there, no discoloration of no history of low complaints of cough, no breathing difficulty, no chest pain, and no reduced urine output. And then past history wise, comorbid, he is already a known case of diabetes mellitus. He was an oral hypoglycemic agent, and then no other comorbidities other than that. He is actually an already diagnosed case of DCLD 1.5 years back with portal hypertension. And then like family history, no significant family history, and then personal history wise is actually alcoholic since 20 years, but once after DCLD was diagnosed 1.5 years back, so after diagnosing he has not consumed alcohol. And then occasional smoker, and then like normal bowel and bladder habits. Like in the last 1 to 2 months, altered sleep pattern, they complained, the patient was complaining, like increased daytime sleepiness was there. And then treatment history wise, for diabetes he was on like metformin, twice daily he was taking, and then for DCLD he was taking rifaximin, and then lactose syrup he was on, no other drug allergies. And then so like summary wise, history wise summary is like 50-year-old male, like chronic alcoholic, who is a known case of diabetes mellitus and DCLD, presented with now abdomen distension and pedal edema, with the past history of recently diagnosed DCLD with altered sleep pattern. So like by history wise we can like confirm that like patient having GI like involvement, most probably like
chronic
liver disease
with
with
liver disease,
disease
chronic liver disease
with decompensation and then with portal hypertension.
With you have to tell a complete diagnosis. See, you are a medicine
sir.
PG. You know that it is portal hypertension. You know that it's a chronic liver disease. Other components you have to tell, and why he has come to the hospital. Everything is explained in your history. That is given in detail.
Yes.
Okay. So it's a chronic liver disease, alcohol induced. Then you are telling it is portal hypertension. Then what else? He's having altered sleep rhythm. You have mentioned
with hepatic encephalopathy. Grade 1.
Grade 1. By history it is grade 1. You have to tell in detail.
Yes,
okay. And why he is admitted to the hospital?
He was admitted with like H1N1, like recent
infection.
History of
so there is a
LRTA.
Suspected LRTA
infection
okay.
was there. General examination wise, patient was conscious, but a little bit confusion was there.
Okay.
He is well built, nourished, and then he was.
So if he is confused, then next stage of your diagnosis should come immediately. What will become? Is it grade 1 or grade 2 or grade 3? He's going towards grade 3. Grade 2 is altered behavior is not there. Grade 3 onwards, patient develops altered behavior. So immediately your diagnosis is changing. So you should, in mind itself, you should be ready for your final diagnosis.
And then patient was febrile, and then pallor was there, and then no icterus, no cyanosis, and then bilateral mild pitting pedal edema was there. Like alopecia was there.
So pallor is there. What is your next diagnosis?
Anemia secondary to any like upper GI bleed.
Upper GI bleed is the
will
most
be
common
more
cause. You should be ready for your final diagnosis. I am telling you, whichever finding you are seeing in this case, your final diagnosis should be added all these things. So patient is having anemia. Okay, what is the reason for anemia? In chronic liver disease, it's most probably it's upper GI bleed. But there are other reasons for anemia in chronic liver disease. What are the other reasons? If it is just because of GI bleed, then it is an MBBS diagnosis. What happens to bone marrow in chronic liver disease?
Suppression.
Bone marrow suppression can occur. A lot of toxins are there. They can produce bone marrow suppression. What will happen to the spleen in chronic liver disease?
Splenomegaly.
What will happen to the RBC because of splenomegaly?
It will like
It is destruction.
The destruction
So a
will happen
postgraduate should think in a different way. It is not an MBBS case presentation. So chronic liver disease is there, portal hypertension is there, anemia is there. So reasons are multitude. So you have to think in that way. Otherwise, what will happen? You will be thinking only about chronic liver disease and GA bleed. If you are not seeing GA bleed, then what is the reason for anemia? Should search for that. Okay.
And then alopecia was there, and no mudrosis.
Is it alopecia is a part of chronic liver disease?
Yes.
Hmm?
Yes, sir.
So where else you check for that?
Axillary hair,
pubic hair. All these things you have to mention. So once you tell alopecia is a general problem. Yes. Even chronic liver disease or without liver disease you can have. Once you tell alopecia, is it due to the liver disease or not? For that you should check for the axilla and pubic hair. In female, what will happen? Best okay.
Mild parotid bilateral enlargement was there.
That is a finding seen in alcoholic liver disease.
No subconjunctival hemorrhage, prominent malreminence, no loss of facial hair, no bleeding gums. And then in chest, spider navy was present in the upper chest and then upper abdomen.
What is a typical feature of spider navy?
It looks dilated.
Is it blanching? Emergency medicine, I am telling you, no need. What is it? What you are telling is correct, but how they are going to check it? See, in your examination, everything will be asked. You are telling it is a spider navy. The examiner will ask you, demonstrate the spider navy. How?
One touch. Blanching will.
You have to take a pin and with that you press the central blood vessel. So everything will disappear. Remove it, everything will come back. So that is a typical feature that you should know. Okay. Anyway, we are not going to do all these things in routine clinical examination. But when you are appearing for the examination, you should be ready to demonstrate that. Okay.
And then loss of axillary hair was there. And then mild gynecomastia was present.
Define gynecomastia.
Enlargement of breast.
Enlargement of breast is a lot of obese individual will have
breast glandular tissue.
Glandular tissues more than
4.
More than? All these things are important for a general medicine people, not for emergency medicine. Emergency medicine, I don't think these things are important. A palpable lump should be seen below the areola more than 2 centimeter. This one, thickness. That is gynecomastia. It can be painful or painless. Painful is seen in? Is it painless or painful here? Painless. What are the reasons for gynecomastia in chronic liver disease?
Less androgen.
Okay, so because of the androgenic hormone reduction. Okay, one is that. Second thing? Spinal drug induced. Okay. So is it bilateral or unilateral? Bilateral. Where will you get unilateral? See, all these things are common problem. Here, if you are seeing a unilateral gynecomastia, what you will check? It's you have to suspect malignancy. Okay. If there is a testicular enlargement, what will happen to the this one breast? testicular malignancy. That is one of the common reason where you get gynecomastia other than your chronic liver disease. That's why any young patient come with gynecomastia, painful gynecomastia, surgeons always check the testis. Okay.
In hands, no debutant contraction, no palmar edema, no flapping tremors.
Okay.
Vitals wise, actually, pulse is 72 per minute regular, BP 140/80, respiratory rate 21 per minute, saturation was normal 98%, temperature was 98.4 degree Fahrenheit. Abdominal examination before that, oral cavity, poor dentition was there, no halitosis, no bleeding gums. Inspection of abdomen was distended, umbilicus shifted downwards, averted, but no nodules in umbilicus, no discoloration near umbilicus. All quadrants of abdomen moves equally with respiration. No visible pulsations or peristalsis. Stretch marks were there present. No sinuses, no scars, no tapping marks, no divarication of recti, no dilated veins, no on standing position, no dilated veins. External genitalia.
If there are dilated veins, what will you do? What is the next step?
Direction we have to look.
Direction you have to see. In IVC obstruction, what will happen? Direction.
Downwards.
They are the common problems. IVC obstructed. What will happen to the flow? Flow will be diverted through the peripheral blood vessels. So flow will be from downwards to upwards. Okay. What is caput medusa? You have already told. What is that?
Where is like distended veins around the umbilicus.
Okay. That is due to
portal hypertension.
So flow will be there also flow will be away from
the outwards.
Okay. So you are supposed to know all these things when you are presenting a case.
External genitalia normal, no loss of pubic hair.
External genitalia, what will you check in this patient? It's a male patient, no?
Testicular
atrophy. But we have never seen these testes previously. We have never examined. How do you know that the testicular atrophy is present or not? Size we don't know. We have not examined in the past. We cannot. There are some beads in the endocrinology department. If you go to endocrinology, they have some beads. They'll assess with that. That is mainly in this one. What is that condition? Testicular growth hormone deficiency. In that they'll test it. But elderly individuals will be difficult. So there will be some sensation called a sickening sensation. If you squeeze the testis, pain will be there in a normal male. That will be lost in the testicular atrophy. Okay, that's how we diagnose that. Okay, size it is very difficult. Size will be reduced, especially in growth hormone deficiency and all. Okay.
Palpation, abdomen was no warmth, not tender, no abdominal wall edema. Shifting dullness was present, no organomegaly were not palpable. Spleen also not palpable. No fluid thrill, abdominal girth around 80 centimeter. Percussion wise, shifting dullness was present, and then auscultation.
Shifting dullness indicates what?
Moderate ascites.
That indicates one condition. What is it? You have to tell all typical answers what you give for the examination. Shifting dullness indicates shifting type of fluid. That's all. Shifting fluid. There are different types of fluids in the abdomen. Yes. Some can be non-shiftable. It will be encysted like tuberculosis. Some will be very doughy type, like thick. That also will not shift. Some dullness will be due to malignancies, tumors. That also will not shift. So shifting dullness is only due to movable fluid in the abdomen. Okay. That answer you have to give in the examination.
Auscultation, bowel sounds heard, no bruit or no venous. Other systems, respiratory system, normal.
Why you are looking for bowel sounds in chronic liver disease? Everything there is a reason. What is the reason here? Which electrolyte imbalance?
Hypokalemia.
Hypokalemia can produce reduced movement in the intestine. So that you have to check for that. Now we are not checking because we are getting all reports within 2 minutes, 3 minutes. Okay.
So other systems, respiratory system, normal vesicular breath sounds heard, bilateral air entry equal, no added
What do you
sounds.
want to look in respiratory system in chronic liver disease? Why you are looking for
Effusion,
pleural
pleural
effusion?
effusion.
Okay. Which side?
Right side.
Right side.
Cardiovascular system, S1, S2 heard, no murmurs.
What do you
Nervous,
want to look in cardiovascular system in chronic liver disease?
pericarditis,
Pericardial?
pericardial effusion.
Pericardial effusion. Okay. CNS?
CNS, conscious, he's a little bit confused, but bilateral pupils equal and reactive to light. Bilateral, like moving all four limbs, and then bilateral plantar
Extensor. Huh? Extensor.
extent.
Any signs of
Like
peripheral neuropathy?
peripheral neuropathy.
Yeah, you are supposed to check all these things. You have to check the angle jerk. You are supposed to check the plantars. You are supposed to check the peripheral neuropathy findings. All these things. Okay.
So summary, diagnosis, case of decompensated chronic liver disease with portal hypertension, with hepatic encephalopathy, probably due to like chronic consumption of ethanol.
You have to tell what is the grade of hepatic encephalopathy.
Grade 1.
Great. So you have to attribute that altered behavior for something else now. What will be the what are the reasons for altered behavior in chronic liver disease other than hepatic encephalopathy?
Um, in, like he had a history of recent LRT,
LRT.
like infection, sepsis,
Infection.
precipitated
Okay, then.
hepatic
Then
any eye bleed,
IC bleed.
upper
Okay.
GI
Okay.
bleed.
Then common things first. What is the most common thing? Hypernatremia. Most important and most common problem is hypernatremia. Then bleeding is another important reason. Intracranial bleeding. Then you told something else. What else you told? Huh? Infections. Okay. How do you manage? What investigation do you want? What investigation you have done? What is your final diagnosis after investigation?
First, complete blood count for platelets and then hemoglobin.
Okay.
And then liver function tests to look
Okay.
for bilirubin, albumin, and then to check for PT-INR, INR derangement we have to see.
Ammonia?
And then ammonia levels we have to see.
What is ammonia in this patient?
In this patient, 70.
It is not very high.
Not very high.
Will you rule out hepatic encephalopathy? It is not very high here. Yes or no?
Not very high, sir.
That is a problem. Ammonia is elevated, means elevated. Its value will never correlate with the severity of the problem. That you should remember. Okay.
Then we can do tapping, ascitic fluid tapping.
Why?
He was complaining this
Pain. Okay. You want to rule out SBP. Okay.
In that we have to look for cells, total cells, and then we can send cultures from that cell.
Okay.
Sorry, from fluid.
Okay. If culture is negative, SBP is ruled out?
No, like
it's not ruled out. Cells are elevated. So many different types of SPPs are there. Culture positive SPP is only one type of that. Okay. Yes. What is a SAG?
Serum albumin and ascitic fluid albumin.
Is it
gradient.
important in SBP? SAG values, yes. Albumin values, all these things are important?
Yes.
Why it is important? What is important in that? Yes. What is the relationship of albumin to infection?
Like in an exudative, like albumin is more, like it's more like SAG value, like if more than 1.1 with like portal hypertension, if less than 1.1 we can rule out total hypertension. Like if patient is not diagnosed, only CLD picture is there, with that we can find out, and then we can use it for like causes of ascites with SAG. And with protein can able to rule whether it is infectious or non-infectious.
Finally, what happened to this patient?
This patient actually cells
What is
was
your
in the
final
border
diagnosis?
lines. Like cells was around only 200. It's not
200. It is
fitting
not
into
very high.
it.
Okay.
But neutrophil predominance is there.
Okay. So that also
So
contributes towards your
towards
diagnosis. Okay.
it was started on antibiotics.
What antibiotic you want to start?
Like ideal one is third generation cephalosporin,
Which one?
ceftriaxone or cefip.
Cefotaxime, ceftriaxone, ceftriaxone, sulbactam.
Ceftriaxone or
Which one? Which one you
ceftriaxone.
select? You select one.
Ceftriaxone.
Don't tell me to select.
Ceftriaxone.
Ceftriaxone. Why ceftriaxone? Cefotaxime is not bad. Good. It's also equally
Ceftriaxone.
only drug which theoretically we should not give is ceftriaxone and sulbactam. It can also be given. What is the problem of ceftriaxone in chronic liver disease? It's not actually a problem. What will happen?
INR
INR can be falsely elevated, that's all. But clinically, it will not produce any problem. So, any third generation cephalosporins you can start. What happened to this patient afterwards?
He was started on actually initially on, since his recent hospital admission was there, he was started on meropenem, sir. And then once after counts and then like inflammatory markers and all was improving, so he was de-escalated to potash. And then like bystanders request for liver transplant, any option is there or not. So he
Okay.
working up for that. Patient
Okay.
was working up for like liver transplant.
So, what is King's College criteria? You know that? King's College criteria.
King's College criteria basically used for
Acute liver.
failure.
There are two types.
Two types.
Paracetamol.
Paracetamol.
That most important investigation is which one?
INR.
INR, creatinine, urea, all these things. So that is mainly used in acute liver failure. Chronic liver failure, you always see whether the patient is going repeatedly to chronic liver disease. INR is very important. So what happened to you tried for transplant?
Workup
Workup is going.
evaluation is going.
Okay. Patient is improved.
Yes, sir. After starting antibiotics.
Okay. Anything else you want to tell about the SPP? Different types of SPP. Have you read? Read or not? You have to read all these things. There are different types of SPPs depending on the cell counts, depending on the culture report, everything. What is a common organism which produces?
E. coli.
E. coli is the most common organism. So we need to give only ceftriaxone, cefotaxime or something. Anything else? Nothing. Okay.